to this session on 360 degrees was the program designed by Olympus, and I thank them for that, for giving us the opportunity. So basically, we are covering all aspects of ERCP, so beginners as well as can understand the ERCP better and perform better ERCP. For today's session, it is on biliary stone management. So first of all, it's an honor for me to share screen with two of my teachers. First of all, Dr. Sudipta Dhar Choudhary, from under whose guidance only I started my endoscopic career, and it's a very nostalgic moment for me. And he's the professor in Department of GI Sciences at KMC Vellore. And second speaker is none other than Director of Interventional Endoscopy at AIG, Dr. Sundeep, Lakhtakia, who had a major role in EUS training, and everyone knows him in India as well as all over the world. And his good and his very good smile also everyone knows. So without wasting any time, I think first speaker, I would like to give the video to the first speaker, Dr. Sudipta Dhar Choudhary, who will be teaching us the basics of stone management and how to deal with them.
Thank you, Gaurav, for your kind words. And thank you once again for having me in this webinar on ERCP. So what I'm going to talk on today is on the basic principles of CBD stone management. Before we go into this, I just want to briefly introduce what CBD stones are exactly. And if we look at the classification of CBD stones, we call them between primary and secondary CBD stones. The primary CBD stones are stones which develop de novo in the bile duct. That happens primarily because of bile stasis, especially when you have a large duct. When there's a large periampullary diverticulum which impedes the flow of bile, as in cystic fibrosis, when there's a sticky bile, they can be leading to formation of stones. Infections in the biliary system, as in recurrent pyogenic cholangitis. Any foreign body within the biliary system, which can be in the form of clips, stents, and sometimes even worm remnants like ascaris, can lead to formation of stones. Secondary bile duct stones are stones which drop down from the gallbladder. Now, what is the natural cause of biliary stones, especially the stones within the common bile duct? Not much is known about the natural history of common bile duct stones, but what is known from this data, which is a Swedish registry of gallstone surgeries. This is a retrospective cohort studies of 38,864 cholecystectomies, and amongst them, CBD stones were identified in 3,969 and 3,828 were analyzed. From this data, what we realized is that among the patient in whom no intraoperative measures were undertaken, what we mean by intraoperative measures was that the patients did not undergo either a post-op ERCP or a patient did not undergo an intra-op laparoscopic CBD exploration. In this group of individuals, the risk for unfavorable outcomes was to the tune of 25%. The unfavorable outcomes in this context was pancreatitis, cholangitis, or cholestasis. And this was more so when the CBD stones were more than 8 millimeters. So what it goes on to show is that if we let be the CBD stones to go into the natural course, then more likely that we'll have an unfavorable outcome in approximately a quarter of the individuals. So what are the problems that the patients with CBD stones are likely to have? Can be presenting with biliary pain, cholestasis, cholangitis, and pancreatitis. But sometimes we have the small CBD stones like a 4 millimeter CBD stones which pass out through the papilla without producing much symptoms. And there have been studies, especially in the context of EUS, where the time interval between detection of stones at EUS and then taking them for ERCP, stones which are less than 8 millimeters in size, around 25% of the stones passed out before they could be taken out at ERCP itself. So coming to the diagnosis of CBD stones, the diagnosis starts off with using a biochemical parameters, and here, of course, is the liver function test. Early on, we can see a rise in AST and ALT, but later on, there's rise in bilirubin, serum alkaline phosphatase, and gamma GT. In a Cochrane meta-analysis, which evaluated 5 randomized control trials, we showed that bilirubin more than 1.3 had a pooled sensitivity of 84% and specificity of 91%. Serum alkaline phosphatase of more than 125 has a sensitivity of 91%, specificity of 79%. But what is more important is that all these 5 parameters, AST, ALT, bilirubin, alkaline phosphatase, and gamma GT, have rather a high negative predictive value. That is, if they are not elevated, likelihood of stone is low. But can we still have stones in individuals who have normal liver tests? And this was investigated by Peter Wilcox and his colleagues in a group of individuals who underwent ERCP. And in their study, what they found is that individuals who are more than 55 years of age or of abdominal pain, this is the group of individuals who may still harbor a CBD stone despite having a normal liver function test. The first imaging test we usually choose for evaluation of CBD stones is an ultrasound, transabdominal ultrasound, and that's primarily because it's readily available, it's non-invasive, can be done at bedside, and obviously it's a lower cost test. And again, the Cochrane meta-analysis showed the sensitivity is around 70%, specificity is 90%. But more importantly, what we can see here is that even if you do not see a stone, the probability of finding stones within the bile duct increases even when the bile duct diameter increases. So with the increase in bile duct diameter, the probability of finding stones within the bile duct increases. The other imaging modalities that have been used for investigation of CBD stones include MRCPs. And MRCP has the advantage of being non-invasive, is an established technique widely available, but has disadvantages, namely it's time consuming. It is contraindicated in individuals having cardiac pacemakers, defibrillators, or intracranial metal clips. There can be false positive results also in individuals, especially when there's intraductal artifacts like air, blood, or image reconstruction artifacts can occur, or they can be motion artifacts. False negative tests can also occur, especially when there is a very largely dilated bile duct, or we have small stone in the distal portion of the bile duct. And it is in this distal segment of the bile duct that EUS scores much higher than MRCP, because with EUS, the resolution is much higher than MRCP. And another advantage of the EUS is that ERCP can potentially be performed almost at the same setting as that of the EUS. But of course, it is an invasive test. It requires sedation, and it is still limited in many centers, primarily because of lack of availability of equipment and trained endosonographers. So how does EUS compare to MRCP in detecting choledocholithiasis? In a meta-analysis, what it goes on to show is that the diagnostic odds ratio is higher for EUS and compared to MRCP. And this is primarily so because the sensitivity of EUS is much higher than that of MRCP. So to summarize, when you investigate patients with suspected choledocholithiasis, especially in individuals who have right upper quadrant pain and a cholestatic pattern of liver function test, if they have acute cholangitis, CBD stone on imaging, or a bilirubin of more than 4 milligram per deciliter, then more likelihood that there's a high probability of a stone, and we can proceed straight on with an ERCP. However, if these are not present and we look for other features, that is there an altered LFT? Is the age of the individual more than 55 or a dilated bile duct? If this is there, then more than likely there's an intermediate probability, and this needs to be further evaluated with another form of imaging, either an MRI, MRCP, or an EUS. And sometimes, and with an MRCP, and after the MRCP, if we are not satisfied, we follow it up with an EUS examination. And if a stone is detected, proceed with ERCP. However, if these features are not there, look for gallstones, and if gallstones are present, proceed with cholecystectomy. If negative, then investigate for an alternate cause of right upper quadrant pain. So now coming to it, as Gaurav was saying, ERCP is now considered to be one of the standard of care of management of CBD stone. And certain pre-procedural parameters need to be checked prior to doing an ERCP, primarily looking at the common CBC, the LFT patterns, and the PT-INR. A number of medications also would need to be adjusted, primarily the DOACs, and these need to be stopped at least 48 hours prior to ERCP. Clopidogrel, ticagrelor need to be stopped at least 5 days prior to ERCP. Aspirin can continue. Sedation and general anesthesia depends on the center at which you're working. Now, One of the complications with ERCP, which we all dread, is a post-ERCP pancreatitis. A number of interventions or steps have been incorporated in our day-to-day practice, which have been aimed at mitigating this risk. This include use of a wire-guided technique, avoiding injection into the pancreatic duct, uh, administration of rectal indomethacin, stenting the pancreatic duct. Despite this, we still get pancreatitis. And another new way of dealing with or mitigating this risk of post-ERCP pancreatitis is peri-procedural hydration. Now, this is a meta-analysis of 9 randomized controlled trials, including 2,094 patients. Most of the studies use ringus lactate at a flow rate of 3 ml per kg per hour during the procedure, followed by a bolus of 20 ml per kg immediately after the procedure, followed by a post-ERCP rate of 3 ml per kg per hour for 8 hours. With this, there was a 56% risk reduction of post-ERCP pancreatitis, and the number needed to treat to prevent one episode of post-ERCP pancreatitis was 17. More importantly, none of the individuals who received the high volume of fluid develop features of fluid volume overload. Now, which is the ideal position to do an ERCP, whether supine is better or prone is better, it depends on where we have been trained. Most of our training have been in centers where most centers prefer to do a prone or a semi-prone position, but studies have compared prone versus semi-prone position, and overall the prone versus supine position, sorry, and overall the technical success rate is higher with prone position. However, if you look at the complications rate, especially the cardiopulmonary complications, the cardiopulmonary complications are slightly higher with the prone position. What this meta-analysis goes on to suggest is that in individuals with cardiopulmonary complications, even if you are trained in a prone doing ERCP in prone position, prefer to do that ERCP in that individual in the supine position. Now, for biliary stone extraction, we have a number of accessories which are now available. And for stones which are less than 10 millimeter, which are really uncomplicated biliary stones, I'm not talking difficult biliary stones here, which would, of course would be dealt by Dr. Sundeep in the subsequent talk. The two most commonly used accessories for stone extraction is a balloon and a basket. Now, this is a biliary balloon, and with that, what we do with the balloon is that the balloon is advanced into the bile duct over a guide wire, and the balloon is inflated above the stone, and then the balloon is extracted from the bile duct along the axis of the bile duct. When you say of the axis of the bile duct is to keep the direction of the balloon extraction in this manner. This will help the stone come out easily. Now, when we have, like in this scenario where there are multiple stones, we start off with the distal-most stone, and as we progress, we start off with the more proximal stones. This is done so as to prevent the stones from impacting, all the stones from impacting at the distal end. If you start off with the proximal stone, we will end up impacting all the stones in the distal common bile duct. The other accessories for stone extraction is a basket. Now, the basket is used to entrap the stone within the wires of the basket. And again, the extraction technique is similar to that of a balloon. That is, we pull the basket along the axis of the bile duct. Now, balloons have been compared to basket, and there's a two multi-center randomized controlled trials done in Japan in 2 subsequent years. One was in 2016, 158 individuals. The population involved bile duct stones less than 10 millimeters or CBD and a CBD diameter of less than 15 millimeters. Complete clearance was higher in individuals who had attempted balloon extraction. However, the single session clearance was not significantly different in both the groups. This is the other study that included 184 patients, and this was also called the basketball study, an interesting name. This study involved bile duct stones of less than 11 millimeters, and there was no limit to the number of stones. This study had a very interesting primary endpoint, that is, rate of complete removal of all stones in 10 minutes. And here there was no difference whether you use a balloon or a basket. What it basically goes on to show is that for stones less than and equal to 10 millimeters in diameter, probably there is not much of difference whether we use a balloon or a basket. And it probably depends upon other factors, that is availability of a balloon and a basket, cost issues, etc. But there can be certain times we encounter problems with a basket, especially when we have a basket which is entrapped within the bile duct, because the stone is bigger, the stone doesn't come out of the bile duct, and therefore the basket cannot be pulled out. Now, with a balloon, the option is that the balloon can always be deflated and pulled out, even if the stone is not coming out. But that doesn't happen for a basket, because once entrapped, it's very difficult to disengage the wires of the basket inside the bile duct. And therefore, in these circumstances, we need two most important accessories. One, of course, is a plier, which is a very helpful accessory, and any form of a lithotripter. What we have in our center is a Sohendra's lithotripter. And so with the Sohendra's lithotripter, we have two other lithotripty accessories. This is a through the scope lithotripter, and this is without the scope lithotripter. And what we do here is that with using the plier, we cut the distal end or the handle of the basket, and we feed the lithotripter over tube. We feed the basket over wires through the lithotripter over tube. And through the scope, this is passed into the bile duct, and then the stone is crushed against the lithotripter by cranking the Sohendra's lithotripter. And in circumstances where we still fail to remove a stone after a basket or a balloon extraction, the options include placement of plastic stents. And this has been investigated in multiple retrospective and prospective studies. And here I've just summarized data from 3 prospective studies, including a total of around 100 patients. All the studies have used a 7 French or 10 French straight stents, and the duration of stent placement was for 6 months. The overall success rate was 75 to 90%. To summarize on the basics of CBD stone management, irrespective of symptoms, CBD stones need to be extracted. Liver function tests and ultrasounds are the initial tests of choice for suspected CBD stones. In patients with intermediate probability of stones, we need additional imaging in the form of EUS and MRCP. ERCP is the preferred mode of CBD stone extraction. In patients with irretrievable stones, plastic stenting for 3 to 6 months and a reattempt at stone extraction will help in extracting those stones. Thank you for your patient hearing.
Thank you, Dr. Sudipta, for such a lucid lecture. I think there must be a lot of questions there, but we will take it at the end of the second lecture, then we will have a discussion. So next, coming to the next speaker, Dr. Sundeep Lakhtakia, Director, Intervention of Endoscopy at AIG. Over to you, sir.
Thank you, Gaurav, and good evening, Sudipta, and all the people who have joined in this ERCP 360. And that's a very nice name. Total coverage of all endoscopic procedures by ERCP. I'll be speaking on in this session on difficult bile duct stones management by endoscopy. Before I go further, let me just define it more specifically. There are 2 terms which are commonly used interchangeably. One is large CBD stone and one is difficult CBD stone. What is the difference between the 2? A large CBD stone is one which is more than 15 millimeters. That's the size category, size criteria. But difficult CBD stones has several definitions, and many of them can encompass in this category, which also includes large CBD stone, or there are multiple large stones which are stacked one above the other in a non-dilated duct, and hence difficult to remove by a standard ERCP methods, or a stone which is impacted or adherent, or a stone which has a very unusual shape. Especially the square-shaped stones are very difficult to remove. The ones which are smooth and round are much easier. Stones which are located above a stricture, even a small stone can also cause a problem. And how to tackle that, we can discuss. Stones in unusual location, that is intrahepatic duct stones, cystic duct stones like merices which cause biliary obstruction, or a stone when the bile duct is not accessible easily and has a diverticulum, papilla is deeply hidden inside, so not able to reach or access, and some other anatomical alterations like large perimeter diverticulum as said, or a sigmoid or a narrow distal CBD with a large stone above, or a post-surgical scenario where Bilirubi 2, Roux-en-Y, gastric bypass surgery, and so on and so forth. So we'll touch upon all these problems and how to tackle them in this talk. So some of the stones can be giant stones. You see, these are very large stones filling almost entire CBD. And this stone is almost more than 5-6 centimeters in size. Another stone which is 5 centimeters in diameter in the vertical length and 3 in the horizontal diameter. Although the duct is quite dilated also, but these stones are giant stones. Occasionally, you can have the lower CBD, which is relatively narrow, although normal in caliber, but upper CBD is dilated with a stone. So this won't come out easily through the lower CBD. Or you can have a very thin CBD below and a larger stone above. So there are several permutation and combination which can occur for these difficult CBD stone. So the basic principle of removing this large CBD stone or difficult CBD stone is if we can increase the diameter of the biliary sphincter or the lower CBD by either wide sphincterotomy or a large balloon sphincteroplasty. Or if that's not possible, try to reduce the stone size on top so that the fragments can then be taken down. So either the exit gate can be widened or the material which has to come through the exit gate can be made smaller inside. That's the basic principle of managing these difficult CBD stones. And how do we do that? So there are devices which can go inside the bile duct and break these stones. For example, mechanical lithotripsy, as Sudipta was mentioning earlier, where you can crank these stones inside the duct, or other methods is using a laser lithotripsy, which can go through a mother-baby scope or a cholangioscope spyglass and break these stones with laser lithotripsy. Or another device which can go through these baby scopes is the EHL or electrohydraulic lithotripsy. But we can also crack these stones from outside by giving extracorporeal shockwave lithotripsy, which we use quite a lot at AIG. And we can discuss this as the talk goes forward. So what is this CRE balloon dilatation of the biliary sphincter, or EPLBD? As the name suggests, the expansion is endoscopic papillotomy and large balloon dilation. The papillotomy is generally small, and then we use large balloon, almost same diameter as the lower CBD diameter. It should not be more than the lower CBD diameter, otherwise the risk of perforation of the bile ducts can occur. So the indications for this EPLBD is that you use in patients who have dilated CBD with single or multiple large calculi. And ideally, you can go up to 13 to 15 millimeters of the balloon. Try not to go higher unless the bile duct is quite big in size and the lower CBD is not so big. The relative contraindication for this is very tight stricture in the lower CBD, which can lead to risk of perforation, as mentioned earlier. And what's the tricks and tips of doing this EPLBD is do a small sphincterotomy, then do a balloon size. Average is 15, but you can go up to 20. But this diameter depends more on the distal bile duct than anything else. So never use your ego to just take out the stone, but cause more harm to the patient. That's one dictum I would like the audience to understand. And decrease the size if the calculus is small or the CBD diameter is small. How long do you inflate this balloon? It varies from 1 to 2 minutes, although there are publications which say up to 5 minutes you can keep it inflated without any difference. There's not much of a difference, but generally most people, most centers who are doing EPLBD keep from 1 to 2 minutes. Always remember to slowly expand and slowly deflate. Never do in a hurry to reach the target diameter of the balloon. Slow insufflation with saline or contrast and saline mixed and vice versa. So let me show an example of this. This is a typical CRE balloon which goes over the guide wire. And this is a sphincterdome being used to cannulate the bile duct, which has a large CBD stone. So first do a small cut. Don't cut all the way till the end. Just a small cut is good enough. Leave the guide wire inside, then pass the balloon and gradually inflate to the desired diameter, as I mentioned earlier. You can go in a graded fashion. Say if it's a 12 to 15 millimeter balloon, insufflate till 12, wait for half a minute, go to 13.5, wait for half a minute and then go to 15 and hold on for a minute. Once you have done that enough, then you deflate and slowly pull out and then use an stone extraction balloon to remove the large CBD stone. These are very gratifying procedures. If you just do a big cut and try to remove the stone, you can struggle and can cause complications. The other way to remove these stones is by basket, as Sudipta was mentioning earlier, or by laser lithotripsy. Baskets are two types, where you just catch the stone and pull it out, or you catch the stone and crank them up inside the bile duct and make them pulverize into smaller fragments, and then those fragments are removed in a standard way. Other way is to do laser lithotripsy using a spyglass cholangioscopy. So this is what Sudipta was showing earlier. There are several types of mechanical lithotripsy available. I will not touch upon those. But the principle of doing a mechanical lithotripsy is you catch the stone and don't drag it out like this. If you do like this, then you'll always tear the papilla open. The best is to catch it, keep it in the mid of the upper part, and then try to rotate so that the cranking happens within the duct and not at the papillary area. Something like this, you catch hold of the stone with the basket properly. It should not be an eccentric trapping. It should be a all around uniform trapping. And then as you close, you can see the stone cracking here. Let me show an example of the stone being cracked, which has been caught by a basket but is being broken in the stomach, just to demonstrate how it is done.
We decided to perform mechanical lithotripsy of
Saw that? So that's how the stone is broken. Slowly crank it up, slowly tighten the screws, and then the stone breaks within the duct. And those fragments then can be extracted out. To see it under fluoroscopy, so first you have to catch it very well. Ensure that it has been trapped well within the basket, so all the wires are equally distributed all around it, not on one side of the stone. And then you take the metallic sheath up and then tighten the screw so that this not rubs against the stone and breaks it inside. As you see, the small fragments are made. And once the small fragments are made, then you can remove either with the same basket or a different basket, smaller basket or a balloon. So what's the success rate of mechanical lithotripsy? If the stone is less than 2 centimeters, the success rate can be as high as 100%. But as the stone becomes bigger in size, then the success drops. Above 3 centimeters, the success is so low because the stone is never trapped. This basket have a diameter of about 2.5 centimeters, so they can't catch a big stone, or if they will catch it in a very eccentric manner, which will not be effective lithotripsy then. Some of the disadvantages of mechanical lithotripsy is to failure to grasp calculi more than 20 millimeters, occurrence of a stone impaction, or a breakage of the wire. Sometimes stones are so hard that your wire breaks, or sometimes it gets trapped. And then you have to use other methods, as Sudipta was alluding to. And occasionally we have to do more than one session. You partially break the stone and then leave it back with a stent inside, come back a few days later and then do the other part. The other method is electrohydrotic lithotripsy, which can be done either with a mother-baby scope. This is the baby scope which goes through the mother scope and then the EHL probe comes out. Or it can also go through a spy cholangioscope, which is a current fashion nowadays. So it basically gives energy when you touch the stone, and it has to be the probe has to be placed very close or touching the calculi so that it actually causes the breakage. But this equipment is quite fragile and the fibers break quite easily. The success rate varies from 3/4 to 100%. Let me show the example of both of them. On the left panel is the EHL, which is done through a cholangioscope. So you see the probe coming out and touches the stone. As soon as you touch, it releases debris the vision can get obscured. So you have to keep flushing it, make your view better, and keep cracking it either from the center or side on. So you need to have a good flushing mechanism to take it out. On the right panel is a laser lithotripsy, again wire guided with a cholangioscope spyglass. There's a holmium laser which is pointing with this green dot. So you have to aim and shoot without touching the stone. We should be at least 1 or 2 millimeters away from the stone, which is sometimes difficult to control when the bile duct is moving and patient is breathing and you're also anxious in a difficult position. But nevertheless, as you touch the stone or just a few millimeters away, just aim and fire. And once these stone fragments break, then you can take out with a balloon or a basket. Both are very effective methods, but have their own challenges. They can be time-consuming process. So there are several types of laser available. The commonest is holmium, now currently being used. Spy scope is generally preferred. Success is quite high in expert hands, but also has some complications if you touch the wall. Although it's fairly safe, but still if you keep burning the whole the CBD wall in a very acute position, then it can cause complications of bile leak. So the experience with cholangioscopy and extrahepatic stones is that it decreases the need for mechanical lithotripsy, which is much more cumbersome or laser intensive procedure compared to this laser lithotripsy. It has a higher stone clearance rate compared to conventional therapy, that is stone with a basket or mechanical basket. And there are several studies now which show that the complete clearance can be achieved in a 9 out of 10 patients. And same is replicated by centers all over the world, which use different types of instruments, which spyglass or ultra slim endoscopes, which can go inside. This is another publication which has come quite recently from Germany, where they've used EHL now and found to be quite effective. And they found that the laser lithotripsy is as effective with EHL. So both are quite effective. Whichever is available with the center, you can just keep improvising on that and get good results. So what next? If these are not available, since they're expensive equipment, so in our center at AIG, we actually depend a lot on ESWL. I'll tell you why. The reason is some of the stones are so large that the basket cannot trap it. So mechanical lithotripsy almost always fails. Or laser lithotripsy can take up to an hour or so and still the job may not be completely done. So what we do is, since these stones are radiolucent, we place a nasobiliary tube first, and then under contrast irrigation, we do extracorporeal shock wave lithotripsy. This is the same machine which also breaks the pancreatic stone. So we are heavily dependent on ESWL to break large stones like this, which get pulverized like this. And then you can easily train them out in 1 or 2 sessions. The stone gets pulverized and then can be taken with a third session of Ercp. This is a machine which is used for the purpose. It has both X-ray view as well as ultrasound view to focus on the stones. So what we do first is, at the first sitting of Ercp, when they come, the patient is, the stone removal is attempted by whatever method is possible, by EP-LBD or other methods. If those fail or the operator feels that they're unlikely to come, then we do a sphincterotomy and place a nasobiliary tube. The purpose of nasobiliary tube is that once it is bathed with saline and contrast at the time of lithotripsy, ESW fragmentation is better. And then once the fragments are less than 5 millimeter or so, then Ercp is done to clear off the stones. This is also an experience elsewhere where they have compared ESW with laser lithotripsy. Although the results are 3/4 compared to almost 100% with laser lithotripsy compared to ESWL, but our experience is slightly different. I would say the ESWL is as good as laser lithotripsy if you have sufficient time with you. Some other examples I would like to show is a large stone here, broken down well and then cleared off. This is what we showed earlier. This is the stone example that I showed in the beginning. This is how it looks later on. This was the large stone which I mentioned earlier. Now it's broken down quite well. And the other example that I showed has also come out quite well. So all these stones, any difficult stones can be removed or pulverized, and then ERCP can be done. We published our data almost 10 years ago, and these were the number of patients, 283, and we found that the stone clearance was quite effective in about 84%. And those who had incomplete fragmentation, that is 15.5%, it was partial clearance in 12.2, and totally unsuccessful, that means they were very hard jewels which could not be broken and had to go either undergo surgery or stenting and so on. Of course, these procedures do have their adverse events like hemophilia, cholangitis, if it's not completely drained, and even post-ERCP pancreatitis. And sometimes, since they go through the skin, they also cause purpuric or hemorrhagic spots on the skin, which may sometimes surprise the patient, but they are generally self-limiting and disappear in 2 or 3 days' time. So net, all these methods that we use, it all depends on the size of the stone and the anatomy of the duct. If the stone is 1 centimeter or so, then sphincterotomy and EP-LVD works well. If they're about 2 centimeters, you can do either EP-LVD or mechanical lithotripsy. But if the stones are much bigger in size, then you have to break them by other means, which is EHL, laser, or ESWL. So success of the ERCP and stone removal depends on stone size. Smaller the size, higher the success. And as the stone size increases, the success keeps going down unless you use those novel methods. Let me show you some more interesting scenarios which can occur when you do ERCP and stone removal. What if you're not able to reach the bile duct? And that's where EUS comes into picture, which I'm sure both Gaurav and Sudipta would agree that we're not able to cannulate the bile duct. In this patient, it was an intra diverticular papilla, and we could not just cannulate several times over. So we did an EUS guided roundable procedure. They punctured past the guide wire, and then finally manipulated the guide wire across all. They took a whole turn up and then came out, and then we did caught this wire and did roundable, and managed to clear up the stone and also place a stent. One more example is sometimes these stones only cause bile duct dilatation. More often, very rarely they cause IHBRD, but if it happens, then you can have an intrahepatic access route, as is happening over here. Although we had the papillary stent, pancreatic stent inside, but still could not go into the CBD. So we did an EUS guided roundable. It dilated duct, which was impacted stone below, got the wire across the papilla somehow. The stone is not so big, but since it was impacted, it was not allowing from going below upwards. So we had to come above downwards. And once we came across, it's a tightly impacted, 2 stones could be seen now. And once we could cross it, then we completed the ERCP. But all this process, we could do the clearance and place the stent. It also led to a small leak of CO2, which resolved. So all these procedures have to be done under carbon dioxide insufflation. The new important device which has come in the EOS armamentarium is a rotatable needle. There's one which is called as a beacon needle. As you can see it here, this is like a FNA needle, and as you pull the stylet back, the tip of the needle curves, takes a curve. Let me show you once again. So it's a straight needle, the stylet is being pulled back and it curves to 90 degrees. And this allows the needle to, and can be rotated in different directions. So that's the beauty of it. And this allows the roundable procedures can be performed, which is required in benign indications of US interventions and sometimes even in malignant indications. So we had our experience with a patient like this. It's the diverticulum with the papilla just not visible. And he had stones, as you can see on the MRCP, and which is also diverticulum is here, the PD is here, the stones I can see stacked over here. So we did an EUS guided roundover using this device, rotatable needle. So the bile duct is dilated with the stones visible. So we used the beacon needle, as you see ex vivo, how it rotates once the stylet is pulled back. It comes in 2 forms, 90 degrees and 180 degrees, depending on how much curve you want to take, and you can choose the needle accordingly. So this was a CBD which is grossly dilated, punctured, and then on withdrawal, you cannot turn around. You can go towards the hilum if you want, or you can take it towards the direction towards the papilla. So then we got the contrast, and the guide wire could be manipulated across the papilla, and then we completed with a regular ERCP way after withdrawing the EUS scope and exchanging with an ERCP scope, leaving the guide wire first in. And then you see the papilla still not clearly visible. It's deep inside, and parallel rendezvous was done after that. Let me show you one more example of a patient who had a large hepatic duct stone, common hepatic duct stone, after post-Whipple's procedure. This was almost 10 years ago. He had Whipple's, and now it's a lady who had come back now with a stone. She also had a stricture in the hepatico-jejunostomy site, which was dilated about 5 years back using percutaneous method for when the tubes were kept almost for a year, exchanged every 3 months. But this time she came back with a large stone and a cholangitis kind of appearance, mild low grade. And there was no way to reach because the loop was very long. The rule loop is very long, and at enteroscopy we could not reach it. So we used EUS now. The option was to do a second surgery or do something more novel, which was not willing for surgery. So we tried a fully covered stent first. So we punctured by EUS, passed the guide wire across the stricture into the jejunum, and then placed a fully covered stent, hepatogastrostomy. And you see the stricture, the stent is still very tight in between at the intrahepatic and the capsule area. And we placed a double pigtail inside and left it like that for about 3 weeks. So on day 0, the stent looks like this. It's very tight. The stent went in the difficulty, the plastic stent in the metal. On day 1, it slightly opened up. On day 3, it's little more opened up. And on day 21, it's largely almost fully opened up. And this is the time when we did the second procedure. So this is a fully covered biliary stent, 8 centimeter long, with a double pigtail plastic stent with the inner end in the jejunum across the anastomosis, and this end is in the stomach. And we thought we can go inside, crack the stone, and then remove the stent. So we took first an ultra slim scope, but our scope in a very angulate position could not go across the middle part. In spite of a 10 millimeter diameter, the central part probably was still 8 millimeter or 5.5 millimeter scope could not go in. So we went over the guide wire, but we could not push our way in. So we switched over to a spyglass cholangioscope and then tried to do a laser lithotripsy here. But lo and behold, we tried something, we cracked up a little bit of the stone, but still it's not complete. And this angle is so acute that the spyglass won't take a right angle turn downwards because it has to go without the guide wire, and we are struggling there. So our next step is again go back to ESWL. So we placed a nasobiliary catheter now through this stent and then cracked these stones. So it became well pulverized now, as you can see after the 2 sessions of ESWL. We got him back. We got her back and then used a balloon to push the stones out. The fragments did go out, but you can see the anastomosis is still strictured. And we wanted to tackle this as well to prevent future stones from happening. So we dilated this area with a balloon, 15 millimeter diameter now, the CRE balloon. And then removed the stent, cleaned it up. And as you can see now, the air is nicely seen inside the bile duct. And then left just a double pigtail plastic stent with one end in the on the jejunum and the other end in the stomach. So this is some of the experience I thought I'll share of several ways of managing these bile duct stones, from large to difficult to extra difficult, I would say. Thank you very much for your kind attention. I would be happy to take any questions and comments from you.
Excellent lecture, sir. Excellent lecture. Very novel techniques done at your center for very difficult stones. So I think Dr. Sudipta, are you there? So, sir, one thing I want, as you have shown one beacon needle as an innovator in FNB, now single-use duodenoscopes have also come up, and you must have experience of single-use duodenoscopes. Do they feel same as normal duodenoscopes, or you think that they need more innovation, single-use duodenoscopes?
So single-use
for
duodenoscope
doing this difficult CBD stone work?
Single-use duodenoscope is as good as a regular duodenoscope. They are meant for prevention of infection rather than removal of difficult stones. Having said that, a spyglass can also easily go through it, as we have reported recently in Video GI, a case where it had a large stone, and we could pass the spyglass instead of CBD and did a laser lithotripsy and completely clear it off. So the purpose of single scope, as Sudipta would agree, is only prevention of infection, which is a new risk recently identified in the Western world. But whether it will be as user friendly or cost efficiency wise in India, only time could tell us.
Next question, Dr. Sudipto. If a patient says that he has a 7 mm stone and he doesn't want to get a ERCP done, if he can leave it, or small stone, sometimes patients say it can leave it, how will you counsel them, whether he should go for procedure or not? If it's a very small stone.
So it's like any other procedure or any other medical intervention or for any other medicine. As long as a patient should be in sync with our advice. If the patient is not willing, we should not offer him the treatment. But with that, we should explain to him the risks and the benefits of leaving it there. The risks, obviously, as I had said, is that there is a 25% chance that the patient might develop some form of complications. But also, there have been reports that a quarter of these individuals with that small size stones, which are less than 8 millimeters, pass off the stone spontaneously. So if he's willing to wait, fair enough. Fair enough, but with the caveat that we have already informed that individual that there is a risk he or she can develop pancreatitis or cholangitis in the near future. But yeah, we cannot force someone to undergo a procedure.
Okay, sir. And one more question for you, Dr. Sudipto, is that for beginners, what are the tips and precautions for using basket or mechanical lithotripsy? So you will suggest stone extraction balloon, definitely it is safer, or you will suggest basket, stone versus basket, both are comparable as you showed in your data, but how to go about it? And if you are using stone, how you will tell them to get adequate training to get that access in line, sir?
So, okay, now the first question between stone and basket, for a beginner, whether to use a basket or a balloon, I really don't know what's the right answer to that question. But when I was doing my own training, I preferred to use the balloon because I was more comfortable with it. That's my personal perspective. And when I was training my fellows with it, I used to always suggest that you start off with the balloon and learn how to extract the balloon, keeping it in the axis of the bile duct. Now, when we tell about pulling it out in the axis of the bile duct, is easier said than done. Is to do it under fluoroscopy, putting a big wheel away from you, gently rotating your scope, slightly torquing your scope to the right while pushing it into the duodenal lumen. Now, of course, it's easier to say here, but when you're doing it, just to push the scope a big wheel away from you so that the scope flicks away from the duodenal papilla, and then you gently push it out so that it pulls gives a traction in line with the bile duct. Now, between balloon and basket, what I would prefer, now I think I would still prefer a balloon for a small size stone. I would rather use a basket when I am expecting that I might require a mechanical lithotripsy.
Okay.
I would prefer to use a balloon in all other circumstances. I don't know,
Okay.
Dr. Sundeep might have something else to suggest.
No, I would agree with you. My personal preference also is a balloon. And only thing is sometimes these stones which are sharp can break the balloon, and that adds to the cost, because that is an equally important part in India at least. In the Western world, insurance takes care of everything. So the practices can change. So balloon is a first preference. And then a basket, if it's and baskets are of two varieties. One is a mechanical lithotripsy basket, another is a smaller basket or a flower type basket, which have sometimes different shape, 8 wires and 4 wires to trap the stones. Sufficient time should be spent to grasp the stone. And sometimes the beginners, in the anxiety or the enthusiasm, they just catch it at one end, and then the axis may change. So spend time, you can inject some contrast through it, get the stone in the right alignment, and then trap it. And once you trap it well, then you gradually drag it down. And as Sudipta said very rightly, that the axis is the most important. If you're just pulling it blindly, you will cause more trauma and you'll get stuck. And that trauma can cause bleed, can cause pancreatitis and perforation. All three can happen there. So if you pull in the axis, you put less efforts, less complications happen, and the outcome is much, much better. Same steps. Take your big wheel away, move yourself to the right, and push the scope down.
Very well said. Very well said, sir. Sir, one more question to you, Dr. Sundeep. There is a question asked by Dr. Shrikant. What is the evidence for lab CBD exploration versus advanced ERCP procedures like lithotripsy for difficult stones? If initial ERCP CBD clearance fails, what to go, sir?
So that's a very good question, Shrikant, that you have raised. If the patient has an intact gallbladder and he is also likely to go for a CBD, for a gallbladder removal, it is best the surgeons can do the job better. Having said that, it is also easier for the surgeons to remove a larger stone than a smaller stones. They can miss a small stone in the CBD, which will come to us, but they will definitely remove a large stone. So if they have a good cholangiogram, which clearly shows 2 or 3 stones, they will pick it up at lab exploration, cholecystectomy, and lab CBD exploration, removal of stones. So it all depends on which stage the patient has come to. If it's post lab chole, then you can try everything possible to break the stone or take it out.
Okay. Dr. Sudipto, now you have like all the modalities available: EUS, MRCP, ultrasound, and if a patient comes, which modality you will suggest? EUS versus MRCP? Which one you will suggest and why?
Okay, so it's like this. When the pretest probability of the gentleman or the person I'm dealing with having a stone is high, and I'm still not seeing a stone, I would rather do an EUS and then proceed with the ERCP, primarily because I can finish up both the things at the same time. I don't need to call the person back again for the procedure. Same sedation, put in the scope, see the stone, pull out the scope, do the ERCP, and we are done with it. When the pretest probability is low, and I just want to confirm that my diagnosis that there is no CBD stone, I will do an MRCP.
Sure. And Dr. Sudipto, you think that our other colleagues like physicians, surgeons, they are also more comfortable with MRCP or CT rather than EUS for like, even if pre-test probability is high, what do you think, like in CMC, they are comfortable with EUS more than MRCP, CT?
Well, I think it depends on the practice at which we are in. So certain surgeons would like to always have an MRCP before they do a laparoscopic cholecystectomy. And the reason is not primarily related to the stone per se. It's more to understand the biliary anatomy when they're doing the surgery. They want to know where the right duct is coming in, where the cystic duct is, so whether there's an extrahepatic location of the right duct, and whether there's an aberrant right duct coming in, so as to prevent the post-lapse complications. And I don't think so it's primarily related to the stones, because everyone understands the sensitivity of EUS. It's more to understand the nuances of surgery. So I think that's what it is all about, choosing MRCP and EUS. So when the surgeons ask for an MRI, it's primarily to help them understand the roadmap for their lap surgeries. And
Okay,
if they
sir.
get information of the stone, that's a bonus.
I would
Okay,
like
Dr.
to
Sun-
add over here.
Yes, sir. Yes, sir.
What Sudipta said is and correct also. MRCP can be objectively seen by anybody, whereas EUS is observer dependent. So it's a man behind the machine which is important than the machine itself. Also, tiny stones which can often be missed by MRCP, especially microlithiasis, which have a cause for the problem in a patient, be it abnormal LFT or mild pancreatitis. So those things are better seen on EUS. So EUS has a higher sensitivity for picking up tiny stones, especially if the duct is thin.
Okay, so Dr. Sundeep, two questions to you. If you have difficult CBD stones in under two settings, one is pregnant patient, one is patient with portal biliopathy. So how will you do in these two settings? You have a stone disease, difficult stone in these two settings.
In a pregnant patient, my first aim is to just drain the biliary system and try nothing heroic, because I cannot use fluoroscopy, and let the patient deliver safely first. And then maybe a few weeks after that, then we can consider tackling the stones. Then we'll know what the anatomy is also and the size of the stone, because at this time we just know the stone is there, which may be big, may be amenable, may not be amenable. So I will not inject any contrast and do under no fluoroscopy with just bile aspiration on cannulating with a guide wire. Now the second scenario is a patient who has a biliopathy. Biliopathy means that the patient has portal vein thrombosis. He has several collaterals in and around the bile duct, which may be projecting inside, maybe compressing the bile duct, or maybe have caused some kind of a stricture there. And that I need a good roadmap before, which includes either an MR venogram, which will tell me how the portal vein anatomy is, where all it is blocking, and a good cholangiogram at the time of ERCP2, and then take a call accordingly. So if it is a varices which are projecting inside, I will be very hesitant in being aggressive in that patient, because that can bleed. So here I would probably use an intraductal methods of breaking the stone. If it is above the stricture, that is either laser lithotripsy or EHL under direct vision. So I'm avoiding the varices. I will try to drag the stone away from the varices if they're very close to it, by pushing with a balloon or just flushing with saline so that they go above it or below it, so that they're away from the field of the potential bleeder. The second scenario which sometimes can occur is a stricture which can occur because of ischemia. They have compressed the bile duct for a long time, and that causes ischemia, which an IDUS can also help. Intraductal ultrasound can tell us. In that scenario, I would again be very hesitant in removing the stone straight away. I would probably place a fully covered stent or a multiple plastic stent, and then try to dilate the stricture, which can also drain the bile duct, and stone will not cause a problem then, and then tackle the stone few months down the line.
Sir, two things. One thing, do you prefer intra procedure hypotension or low BP while doing tackling with biliopathy patients? Sir, like take systolic BP around 90-100, not going more than that.
That has been explained by Dr. Malay and several times in his experience. Personally, I don't use it unless somebody bleeds. I give a injection that time, a terlipressin injection. One more thing I was trying to have.
Prophylactic terlipressin, do you recommend, sir, or only at the time of bleed?
I haven't used it, and I don't use it. I use it only if somebody bleeds. If it doesn't, then I don't use it. One more thing I would like to highlight here is not to use a straight stent in biliopathy.
Okay, sir.
I will repeat it again. Never use a straight plastic stent for biliopathy. The reason is the straight stents have flaps, and if the varices is projecting inside the time of removal, that flap can avulse a projecting varix in the bile duct, and that can be a disaster. And if that disaster happens to occur, then Sudipta, I think a good idea to have a fully covered stent to bail us out.
I think sir, just to add on to it, in those circumstances, is that I would. This is a very important point to discuss, actually, because it's a very relevant to our circumstances where we deal with. In scenarios where individuals centers which do not have access to intraductal lithotripsy, like either EHL or laser, in those circumstances, between balloon and basket, would basket be a better option between a balloon and a thing? Would an open basket with gradual trawling or a balloon? I really don't know, sir, because I'm asking this question because I really don't know. And it's always been a thought in my head that which I would choose, because I've been using basket and a balloon. I didn't have a bleeding, touch wood, but so I never know.
This is a difficult scenario. So you look at the cholangiogram. So you need a good fluoro machine, number one, where you can have good frames which you have captured, inject cholangiogram and see where the projections are. Those smooth indentations on the bile duct will tell you where the varices are lying. And then depending on the caliber of the bile duct and the stone which is above, is it likely to come out or not? I agree with you, a basket sometimes is better than a balloon, but either thing can cause a problem. So you have to be
And
really and select patients. If a complication happens, are you able to handle that? If you're not able to handle, please do not try to do heroics there. And these are the patients which should be referred
And the
wherever
other
it's
thing is
possible.
that you should always try, if you're doing such a case, as much as practicable, keep your wire within the ductal system. Do not lose your wire, because once it starts to bleed, the whole vision goes away for a 6, and you have to probably at that point of time go for a blind stenting. I don't know. So
It's a
it's
difficult thing. So never lose your wire. Wire is your lifeline, as you rightly said. This problem is more of Indian subcontinent. Portal vein thrombus is not seen by the Western people. It's only an Indian problem, and we should have our own ways and means of tackling it. So if your backup is not available, just place a stent and come out of it, and have a safe practice than a complication which is going to.
because a couple of times when we have done EUS in those circumstances, just to see what the bile duct anatomy and the portal vein is, you actually cannot see the bile duct. Even if you put the Doppler on, you have to search for that bile duct inside that mesh that is there. And so you can imagine the fear that you have. It's a very valid point, Gaurav. Thanks for bringing this up.
And next question to you, Sudipta. As you told about prevention of post-ERCP pancreatitis, you are hydrating according to RL. Someone has asked about whether to use rectal indomethacin versus rectal diclofenac. And do you give to your patients in these medications to prevent
I
this
think
complication?
everyone in this current scenario, anyone who's undergoing ERCP should have a rectal NSAID administered. There's no question about it. Now, there is enough data to support administration of rectal indomethacin, and that I think should be current standard of care. There is no question about deciding on that. That is current standard of care. Now, beyond that, once we have the wire, if the wire inadvertently goes into the pancreatic duct, what I do in my thing is I leave the wire there and I actually put a PD stent when I'm coming out. This is just to keep a safeguard of an additional factor. Despite having a rectal indomethacin and a PD stent, I've had post-ERCP pancreatitis. And I think many of us who have done ERCPs will tell that have had post-ERCP pancreatitis. So this hydration is just another additional step to mitigate the risks.
But that incidence must be only of mild pancreatitis after these interventions. The patient must have, your patients who had must have mild pancreatitis only after all these.
Whole thing, you can never predict about pancreatitis.
That's true.
Yes, yes.
Until the patient is out of the hospital, I am not very sure.
So I will just expand on that, is that at AIG now we have a policy of all patients going for ERCP, they have a rectal endomethacin placed before they come to the room. And a sticker is placed on the file at what time it was placed. Whether it's a chronic pancreatitis, high risk patient, low risk, everybody, we don't want even 1% chance. If it happens, that's just bad luck, but try to make all efforts to prevent it, as Sudipta rightly mentioned, by rectal endomethacin, IV fluids, PD stent, and so on.
So next question.
But PD stent, sorry, I'll just take one more thing I would add.
Yes, yes, sir.
The guide wire goes into the
Sure.
PD. It is, keep the guide wire there. Don't place straight away a plastic stent in the PD. Finish your biliary work, and then in the end place a plastic stent. Because once you place a PD stent, sometimes the entry into the biliary tract becomes a little more challenging now. And that small opening will not allow, then you end up doing pre-cut, which another adds to the risk. So keep the wire, which will help you in the end. Agree?
Okay. So next, yes, sir, absolutely. Next question to you, Dr. Sundeep. This you have everything available: ESWL as well as EHL as well as lithotripsy. We at our center use EHL, but these instruments used to direct instruments are, you can visualize stone well, you can crush, but these are very fragile instruments. Even in large stone, they may require 2-3 settings. And how you counsel such patients, like how many settings? And ESWL, why it's not popular all over India? Like it's very few centers who are using ESWL as effectively as AIG, sir.
ESWL actually is It's a good machine to have first. These are not equal to the machines used by urologist. Most centers actually use the machine used by urologist and extrapolate it to pancreatic or a biliary stones. They will not crack up and you will lose faith in these machines. So they need a higher settings where the intensity is high so that you can crack them well. You need a dedicated person who can do this job in and out. It cannot be a part-timer coming one day here and another person coming someday there. So those, as you keep doing this, also is an expertise area. So luckily we have a person who just loves to do this, and he has been doing it for more than 10 years for us. He's an excellent guy and he's dedicated to it. So passion, hard work and persistence always pays, and so does in anything, so does in ESWL too. And we believe that to save our time too, ESWL can be done, we can delegate to somebody else now who does this job better than us, rather than struggling for 2 hours of doing a laser lithotripsy and ending up saying, oh, we only finished half it, we'll do it next time. So now the cost multiplies. The expensive the spyglass is expensive, the probes are expensive, so is the EHL probe is expensive. So again, that's the choice which an operator has to decide. How much likely is he going to go further rather than just for his ego, if I can use that word, or then stop somewhere. So you have to make your own limits. Till what level would you like to go?
Okay, sir. So like for sir, like patients who not at tertiary centers who are practicing at secondary centers, how many sittings you should say, like you even like next sitting might be easier than the current sitting, but like when you should refer to a surgery or a CBD stone if you're not able to remove
most CBD stones or for that matter pancreatic stones break in 2 sessions, 1 to 2 sessions generally they require. If somebody is requiring 3 or more, the likelihood of that stone breaking is much less. So in that case, we will ask for alternate options of like surgery and other things.
Okay, sir. And
what I
yes,
feel
sir.
is that, you know, when you are, sorry, what I do is I usually will do 1 session, and if I feel that I have not had a very good success, I put 2 plastic stents in the gentleman and send him home for a couple of 6 months. Now, what happens in that period of time, I do get see some of the stones which we send over a period of time, there is a reduction in size of the stone, either because of rubbing. I really don't know the mechanism behind it, but the stone size does tend to come down significantly when you have 2 or 3 plastic stents adjacent to the stone. And then we call them back for a second session. But at that point of time, if it doesn't crack, always ask the surgeons. At least that's what I've been doing. Ask the surgeons if they can.
Dr. Sundeep, someone has...
Yes, please go ahead. Hello? Can you hear me? Hello? Sudipta, can you hear me?
I can hear you. Gaurav is thing.
Okay.
Gaurav is muted.
So let's look at the chat box, which is...
There are some interesting questions actually.
So what's
Nice.
the risk? There's an anonymous person who's asked, what is the risk of bile leak and EOS round over the wire cannot pass beyond the papilla? Does a 22 gauge needle has less risk compared to 19 gauge? So we had a master class today in EOS, and that's what was being also discussed there. So we always prefer to use a 19 gauge needle. And risk of bile leak only is there if you have kind of done a fistula creation and not complete the job. So one should be ready for all the options and permutation combination when you're doing an EOS biliary intervention, that how much you are likely to go further. In malignant biliary obstruction, say the obstruction is lower down at the papilla and you have approached by the liver side, and if the wire does not cross the papilla, then you can obviously do hepatogastrostomy. Same goes for choledochoduodenoscopy in a malignant obstruction. But in a benign disease, in a worst case scenario, the wire does not go down, you'll have to keep trying, because now that you have contaminated the system, and it does go down. If there's no stricture, most wires would come down. It is all your patience and your accessories which are likely to make you successful.
I agree.
Yes, Dr. Sandeep.
Yes. Just
Sir,
got a-
sir, sorry, actually there was a break. EHL versus laser. Someone has Dr. Yogesh Shastri from US asked, which one is safer and what is your preference, sir, EHL versus laser?
So my preference is laser. Little more experience personally. That's what I feel. Uh, you can focus. You need not touch the stone. You can be little away and keep irrigating with a spyglass to clear your view. Also, I would say if you have a stone which you know, do not inject contrast. Sometimes contrast obscures your view, especially in malignancies. In stone, it's a different thing, but you want as clear a vision as possible because it makes it a little more glassy if the contrast is there.
Okay. What about you, Sudipta?
I have experience only with laser. I have no experience with EHL. I've used EHL only thrice in my life, and primarily I have virtually you can say zero experience. But whatever little I've seen, I didn't find any much difference as regards the stone fragmentation is concerned. It tends to, both of them seem to work equally well. And with the current generation, the autolith seems to work pretty well. My only concern was that after a particular number of hits, the probe stops working and it had to be changed or at least disconnected and reconnected. That's the only issue I had at that point of time. Probably it was very early on at that time.
Gaurav,
But
you have experience with this. Can you expand on that with EHL?
Yes,
sorry.
sir. Sir, I have experience on EHL, sir. So it's an effective machine, but as Sudipto told that at some stones are very hard, sir, and after 1,000 pulses, it has to be again either reconnected and again or install a new probe. You have a new laser probe you have to take. So only thing is, sir, pricing is an issue because there is one time investment if you are taking a laser versus EHL, you have a recurrent expenditure is more. That is the thing, but only thing is with hard stones, you may require 2-3 settings, and in one sitting you may not be able to. Otherwise, but it is effective, sir. If it's a soft stone, soft large stone, or if it's a moderate size, moderate hardness stone, then it is an effective thing. And we were able to clear many large stones with EHL also.
So the laser machine can also be shared with urologists, and the
Yes.
same can also be shared. So that's an advantage. Laser is much more sturdier and long lasting. Only the machine is there, but the fibers are generally quite sturdy.
Fibers, you can just cut the edge and reuse them as many times as possible. And gradually, at least I have seen that sometimes we've had one guy sitting on the stool because the fiber has become so short that it can be connected only this much length.
That's true.
So Dr. Sundeep, like sometimes we have small stones, but they are impacted and like difficult to remove. Any techniques you have used so that you can disimpact, because there at that time either anything you are not, stone extraction balloon is not working, mechanical is not working because you are not able to grasp. And sometimes even laser is difficult because it's so much impacted at the wall of the duodenum that it's difficult to like disimpact also with laser. So anything, sir, any such cases?
So one clue over here, if the stone is impacted, it's probably in the cystic duct. It's just pointing out it's a Merisi syndrome. So you have to be aware of it. If you have a C-arm, you can rotate and see where the cystic duct is taking off and where exactly it's pointing towards. So that may give you some guidance. Or if it's impacted, you can take a spirocholangioscope and then locate it and then hit it. One more reason of impaction is that if the stone is a lower end and doing a CRE, for EPLBD, you can actually trap the stone within the balloon wall and the CBD wall, and then you expand it and then it goes in the wall now. It's formed a small kind of diverticulum outpouching and the stone gets impacted there. So that we have observed a few times, and that's a very irritating type of procedure, and you end up not doing anything, just place a stent, come back, and few weeks or months later, that stone will expel it out from the diverticulum there.
Yeah, I think what we do with
Yes,
EPLD
sir.
is that we try to avoid having stones in the lower common bile duct. So what I have been doing with my EPLD is the first when I dilate the balloon, I just push the balloon in and out softly so that whatever remnant stone is there is actually pushed up. That's what I have been doing, but sometimes it just pockets out there. And it can be a real pain, as Dr. Sundeep has said. It's very difficult.
One trick that people can try is that use a stone extractor balloon, and as Sudipta said, push it up. And once you exchange to a CRE balloon, don't do any air insufflation or suction. If you do suction, that top stone will again drop down and then again it will get impacted. So at that time, be conscious of your suction and air insufflation button.
Okay. Okay. And just last question, I think, before we wind off, sir. Someone has asked a basic question: how much sphincteroplasty EPLD we should do? How much sphincteroplasty should be done?
So if you have a machine which can measure the stone diameter and the bile duct diameter, that will give you a rough estimate. So whatever looks on the screen, if it's a magnified, it may look big or small depending on how much magnification factor you're using. So the machines which are high-end machines can actually measure it for you, and then you can titrate your balloon diameter according to that. Alternatively, you can use the ERCP scope diameter as your landmark, which is about 11.5 millimeters. So the balloon should be between 12 and 15. I try not to go above 15. I'm not so aggressive anymore. I want to be cautiously aggressive is the term I would. I think the gray hair and the loss of hair probably points to that. You can't see for Gaurav, and Sudipta is also in my category too now.
So I've become cautious very well.
I am also cautious, sir, because I am not a tertiary center. So my limit is also 15 mm, but some centers can go up to 18 mm. Like Dr. Sood may go up to 18 mm. So he's confident, sir. But my also limit is 15 mm. I don't go beyond that. And also assess the size of the lower Cbd diameter and then only proceed accordingly how much I have to expand the balloon.
I think the more important point is to choose the bile duct which is the right duct for EPLBD. Every big stone is not a candidate for an EPLBD. More often than not, in our country, what we have is a pig in a python sort of a situation. The bile duct is narrow and the stone is big. And in those circumstances, when the bile duct is narrow distally and you try to blow it open, we are not doing we are trying to dilate the distal common bile duct. That's not the objective of EPLBD. EPLBD objective is to open the papilla, not to dilate the bile duct. So when the bile duct is particularly narrow, in those circumstances, we have to use intraductal lithotripsy or extracorporeal lithotripsy. But when the bile duct is narrow and the stone cannot come down because of the bile duct diameter, EPLBD is not the option. It's only on those circumstances where the bile duct is big enough and there is a papillary stenosis, that circumstances you can blow it open.
Okay, sir, I think we have discussed anything you want to add. Otherwise, I just want to thank from bottom of my heart. I am really humbled that Dr. Sudipta and Dr. Sundeep agreed to speak on this beautiful topic of biliary stones, and it's a very important topic for any endoscopic pan-India, pan-world to handle the Cbd stone efficiently and safely for patients. Thank you, Dr. Sundeep.
Thank you, Sundeep. Thanks a lot, Sundeep.
You and Sudipta.
Thank you, sir.
It was a very nice. Bye-bye.
Thank you. Bye, sir.
Good night.
Bye.